Good evening. Tonight we're here for Lighting the Path in Early Breast Cancer Care, Uniting Evidence, Expertise, and Multidisciplinary Action. Sorry, my advancing is... Going to take a moment just to introduce our faculty for tonight. I am Laura Dominici. I am a breast cancer surgeon located at Dana-Farber Cancer Institute and Beth Israel Deaconess Medical Center. And I have joining me tonight two colleagues who I'll ask to say a little something about themselves. First, we have Dr. Olga Kantor.
Hi, I'm Olga Kantor. I'm a breast surgical oncologist at Northwestern in Chicago.
And also joining us, we have Dr. Abou Hussein.
Hi, I'm Abou Hussein. I'm an assistant professor of medicine at Cooper Medical School of Rowan University and an adjunct assistant professor at MD Anderson Cancer Center and a breast medical oncologist.
So we would like to thank you all for joining us, those of you who are in person and those of you who are joining us online. We would like to thank PeerView for providing this session. And we would also like to thank AstraZeneca and Merck and Company for providing the educational grants for this symposium. If you have not already, please complete the pre-event survey. And we're hoping to make today's session interactive. So please do take part in the polling throughout the session and submit your questions for us at any time. For our in-room participants, you can use your personal device to scan the QR code on the next slide to respond to polls and to ask questions. And for our virtual participants, please do respond to the polls on your screen and answer questions in the chat window. We also have a little enticement to get you to participate with us tonight. For the in-person learners, as you participate, each action is going to increase your chances of winning a $50 gift card. This would include completing our pre-event survey, answering the polling questions, or submitting questions to the faculty. You can see here the icon that will appear on your screen if you have won a gift card, and then please see a PeerView team member to claim your prize. We would like to thank PeerView for providing the gift cards tonight. And these slides and the practice aids that we referenced tonight can be accessed in the activity menu now and then downloaded after the session. If you would like to visit PeerView, the address is there, as well as the email address if you would like more information or have questions, as well as the way that you can join our conversation on Twitter, or X, sorry. Our goals for today, during this presentation, we are going to learn how the latest advances in systemic therapy are reshaping outcomes across early breast cancer subtypes, why modern ABC care requires individualized integration of systemic therapies within multimodal treatment plans, and that implementing best practices for multidisciplinary collaboration and coordination is essential for optimal patient care in early breast cancer. We'd like to ask you to first answer this question on your device. Which of the following represents key practice challenges for you in the care of early stage breast cancer? Number 1, coordinating multidisciplinary care, e.g. imaging, systemic therapy, timing, pathology turnaround. 2, optimizing surgical planning and axillary management. 3, selecting and integrating systemic therapy advances into surgical pathways. 4, postoperative response assessment to guide adjuvant therapy decisions. Or 5, all of the above are challenging areas in current practice. Great, so we have a lot to talk about tonight. We're going to start off by talking about early stage triple negative breast cancer. We're going to start with a case of June, a 40-year-old woman who is diagnosed with an early triple negative breast cancer. She was diagnosed with a T2N1 triple negative cancer and subsequently underwent neoadjuvant chemotherapy with carboplatin Taxol and AC with pembrolizumab with the KEYNOTE-522 regimen. She had breast imaging following her neoadjuvant chemotherapy showing a decrease in the mass size to 0.8 centimeters, normal appearance of her axillary lymph nodes. She did have panel genetic testing that was negative, and she underwent lumpectomy and sentinel lymph node biopsy following her treatment, revealing 4 millimeters of residual disease in the breast and negative lymph nodes. So our question for this is going to be, what would you do next? And we'd like you to keep this case in mind. We'll be discussing this after reviewing the evidence. We're going to ask you to answer your question on your device to start here. So what would you recommend as the best systemic treatment approach in addition to radiation therapy for June, our 40-year-old woman with T2N1 clinical triple negative breast cancer, negative genetic testing, now having received neoadjuvant chemotherapy with pembrolizumab with 4 millimeters of residual disease in the breast and nodes negative? Number 1, stop pembrolizumab after surgery, observation to avoid additional toxicity. Number 2, adjuvant pembrolizumab continues. Or number 3, continue the adjuvant pembrolizumab and add capecitabine. Or number 4, I'm not sure. All right. So we're going to start our discussion by having Kamel come up and go over some of the evidence around early stage triple negative breast cancer.
Thank you, Laura. All right, perfect. So we'll start talking about the data for early stage triple negative breast cancer. And this is a schema for the management of this subtype of breast cancer. So if we focus on locally advanced triple negative breast cancer, so stage 2 and stage 3, for those patients, the standard of care was set by the KEYNOTE-522, which is an intense regimen that is formed of a backbone of 4 chemotherapies, paclitaxel, carboplatin, anthracycline, and cyclophosphamide along with pembrolizumab, and then patients proceed with surgery. What dictates the management after that is the kind of response that we get. So whether we achieve pathologic complete response, where the standard of care is to continue 9 more cycles of pembrolizumab, or no PCR, where the patient proceeds typically with continuation of pembrolizumab, and on top of that, the patient would be eligible for capecitabine according to the CREATE-X trial. If the patient harbors a BRCA germline mutation, they would also benefit from 1 year of adjuvant olaparib. So this is a CREATE-X trial, a very famous trial that a lot of us are very familiar with. And in that trial, which looked at HER2-negative breast cancer that received neoadjuvant chemotherapy and ended up with residual disease, so it did include hormone receptor positive and triple negative. There was a pre-specified subgroup that focused on triple negative. And here you can see that there was a significant improvement in disease-free survival at 5-year analysis, with an improvement from 56 to almost 70%, with a hazard ratio of 0.58. OS benefit was also noted with an improvement from 70 to 78%. And again, the hazard ratio was 0.52. So basically, we are doubling the chances of our patients surviving without progressing or dying from their disease. And that was very practice-changing. This is the KEYNOTE-522. As we said, this is for all comers, locally advanced triple-negative breast cancer. And we've seen here that there is a significant improvement in PCR rate with a delta of 14%. And that did apply to all comers, whether you're PD-L1 positive or PD-L1 negative. So you can see here on the right side that patients that had PD-L1 positive disease, definitely those are going to be the patients that derive the most benefit. They had a 14% delta, but the same magnitude of benefit was seen in the PD-L1 negative. Not only that, but we always care about event-free survival. So PCR is sort of the initial marker of benefit, but we want to see a decrease in the feared event, whether it's recurrence, whether it's death. And here we can see that there was an improvement in EFS with a hazard ratio of 0.63 and an improvement also in OS. And that was improved from 81% to 86.6% with a hazard ratio of 0.66. Another very important trial is the Olympia trial that focused on our patients that harbor a BRCA germline mutation. And those are patients that are stage 2 or 3. They could have been hormone receptor positive or triple negative. And those patients could have proceeded with neoadjuvant chemotherapy or patients treated in the adjuvant setting. For the sake of our discussion here, we're going to focus only on TNBC. And any patient that receives neoadjuvant chemotherapy and ends up with residual disease is high risk by definition. Patients that proceeded with surgery first approach and had adjuvant treatment, if they are node positive or if they had the T2 lesion, they were eligible. And here the intervention was 1 year of olaparib. And here you can see that there was an improvement in the 4-year IDFS from 70 to 79.6% with a hazard ratio of 0.65, and OS was also improved for this extremely high-risk population with BRCA mutation. There's a lot of ongoing trials giving us a lot of meaningful signals from the use of IO-based therapy for triple-negative breast cancer. Lots of trials. What we have learned from the past few years is that using IO therapy in the adjuvant setting, so after the patient has finished their neoadjuvant therapy and the cancer is out of their body, doesn't really give us a beneficial signal. You'll see here that the design of all of those 5 trials is looking at the neoadjuvant inclusion of different types of IO therapy. And sometimes we've seen also a continuation of the IO therapy in the adjuvant setting. And here you can see that the PCR rate across the 5 trials was improved from the addition of IO-based therapy. I'm just going to call your attention to one very important trial, which is the NeoPact trial here in the middle. What I like about this trial is that an anthracycline-free regimen, so it simplified our Keynote 5-2 regimen from 4 drugs and IO therapy into only 2 drugs with carboplatin and docetaxel, no anthracycline, along with pembrolizumab. And those patients were able to achieve 58% chance of PCR. Now that is a phase 2 trial, and right now another phase 3 trial that is comparing that to Keynote 5-2 is ongoing, called the Scarlet trial. Now, Keynote 5-2 is such a great regimen, but it doesn't come without side effects. And patients who achieve past CR, they always question the decision of what to do after surgery. They have no residual disease. Should they continue? Should they stop? And we get asked so many times by patients, can I stop my IO therapy? So this is an excellent trial, the Optimize PCR, that is exactly taking this population that had a complete response, randomizing them to standard of care, 9 more cycles of pembro versus observation. There's also a translational arm to that study that is we're not only looking at how they fare clinically, but we're monitoring the ctDNA of those patients. The SWOG 1418 is the last remaining trial from the adjuvant use of pembrolizumab, and that trial has finished accrual a few years ago, but we don't have data yet about results. So basically, neoadjuvant treated patients for triple-negative disease with at least a centimeter of residual cancer or a positive lymph node. They were randomized to pembro for 1 year in the adjuvant setting, with or without Xeloda, or observation. Now, this is a very good concept for our patient that has a BRCA-mutated cancer. This Olympian trial, which is a phase 2 trial, is deploying the use of either olaparib by itself in the first part of the slide here, or olaparib in combination with a PD-L1 inhibitor, durvalumab. Here, in low-risk populations, so population that is T1b or T1c and 0, and those patients are being treated with olaparib monotherapy, so chemotherapy-free regimen. And look at the PCR rate here. 68% PCR rate, RCB1 and RCB0 and 1 is up to 72%. Really quite impressive. When they added durvalumab to the higher risk population, so those are T1 and 1 or T2 disease, there was even an improvement in PCR, 80%, RCB0 and RCB1 was 84%. Antibody-drug conjugates. Those molecules which are formed of three different parts. So there is an antibody that is geared towards an antigen on the surface of the cancer cell. There's a payload, which is the chemotherapy, and there's a linker. This triad is called antibody-drug conjugate, and they have made a revolutionary change in the way that we manage metastatic triple-negative breast cancer. They soon, hopefully, will become our standard of care first-line management of triple-negative breast cancer. And there is a concept in medical oncology, anything that works in the metastatic setting always moves forward. We try to treat high-risk, early-stage patients in a trial to prevent them from having recurrence and becoming metastatic in the future. And that is what we're seeing here. We're seeing a lot of trials that are testing the use of ADCs in addition to IO therapy in the neoadjuvant setting. We have the Tropium-Breast04, which used datopotamab deruxtecan plus durvalumab, and that is being compared to KEYNOTE-522. We have the Trofuse-032 using another ADC called sac-TMT or sacituzumab tiromotecan and pembro, and comparing that to chemotherapy, or the HERTHENA trial, which is comparing the use of an ADC against the HER3 antibody, antigen, and that is called patritumab deruxtecan in addition to pembrolizumab. In the adjuvant setting, we have the SASHA trial using sacituzumab govitecan versus treatment of physician choice, Tropium-Breast03 using the same combination as Tropium-Breast04 with Dato and Durva. The ASCENT-05 or Optimize RD. RD stands for residual disease. That one is looking at patients that finished their neoadjuvant therapy and had residual disease and giving them SG or sacituzumab in addition to pembro. And that is being compared to standard of care pembrolizumab and capecitabine. And the last one is the Trofuse-012, which is also using sac-TMT and pembro versus treatment of physician's choice. All right, perfect. So I'll pass it back to Laura.
Thank you. So let's return to our case of June, our 40-year-old woman who is diagnosed with triple-negative breast cancer. Just to refresh us, she had a T2N1 triple-negative breast cancer. She underwent neoadjuvant chemotherapy with carboplatin, Taxol, and AC with pembrolizumab, KEYNOTE-522. And on her breast imaging after chemotherapy, she had a decrease in the size of the mass to 8 millimeters, normal appearance of her axillary lymph nodes. She did have negative panel genetic testing, and she underwent lumpectomy and a sentinel lymph node biopsy, which revealed 4 millimeters of residual disease in the breast, and nodes were negative. So we're going to discuss what would you do next, what treatment options should we consider for this patient. So we're going to run through a few different variations. I'm going to, before we do that, ask you, Kamel, for this patient who had a small amount of residual disease and nodes were negative, what would you be recommending for additional systemic therapy?
Yeah, so the standard of care right now is to continue with the pembro for 9 more cycles and consider adding Xeloda for any residual disease based on the CREATE-X trial. A lot of us have hesitancy about that, though, because the CREATE-X is such a great trial, but it was performed mainly in Japan most of the patients were Japanese or South Korean. And as you know, the triple negative biology in this part of the world is quite different than what we see here in the US. So a lot of patients over there are having sort of the LAR, the luminal androgen receptor, which is very well behaved with the best overall survivor rates. And in the US here, we see basal-like, which is the worst prognosis.
And so what if this patient also did have a BRCA mutation? I know you talked with us about using a PARP inhibitor. Would you give them both capecitabine and the PARP inhibitor? How would you sequence it?
Yeah, you know, it's a discussion, but definitely I always favor using anything targeted for patients that have an abnormality or a target to address. So that would be my preference. If I can use both, I would definitely start with probably Xeloda first because it's a 6 months course, and then after that move on to the PARP inhibitor for 1 year.
And so, Olga, for you, in this case, June obviously elected to undergo a lumpectomy, and she was a candidate for sentinel node biopsy. If I just ask you if she had a BRCA mutation, how might your counseling around local therapy options be different or not?
So of course, in terms of the risk of recurrence, the BRCA mutation doesn't make a difference, and so she's obviously going to be a good candidate for breast conservation. But in terms of the future breast cancer risk, it's substantial in the setting of a BRCA mutation. And there is some nice, large international data that was presented at San Antonio last year and is now published in The Lancet that looked at women, I think, up to age 40 with BRCA mutations, and they actually showed some survival benefit in those patients that had bilateral mastectomies when they had a cancer diagnosis prior to age 40. And so I think that data is really the only data we have to suggest a potential benefit to bilateral mastectomy in this population and should be discussed with patients.
And I think I'd like to make sure we touch on some of the more local therapy pieces in this discussion. So leading us into that, the IO is great, but I understand it does have some things that we as surgeons need to be thinking about as we're taking patients to surgery. Could you spend a few minutes just telling us about that?
Absolutely. So as much as it's effective, but it does come with a high cost of toxicity, unfortunately. So IO-related toxicity can include anything, but even in practice, sometimes we see adrenal insufficiency that can happen from IO-based therapy. On the trial, about 22 patients did have that unfortunate outcome. And even though they are less than 1% of the trial population, but still it's 22 patients. Now that makes a big difference for you as a surgeon because you want to make sure that this is not the case when you take her to the OR so that her blood pressure is stable. And the protocol is typically to hold IO-based therapy about 1 month prior to the OR date. And we measure the AM cortisol level to make sure that this is not the case at all.
And is there any significance to timing for measuring the AM cortisol? Like, is it best to do it right before surgery? Does it matter?
I usually do it in the first, in about 1 to 2 days preoperatively. Yeah.
Great. Yeah. And I think one of the most pertinent sort of local therapy issues this particular case brought up for me is the axillary management, Olga. So in this case, the patient had clinical N1 disease, had a really nice response to chemotherapy, and then was pathologically node negative. So I think most of us at this point would offer the patient a sentinel node. Before we kind of talk about the surgical side of things, I'm going to make you in charge of all local therapy. So tell me, if you are sending this patient to a radiation oncologist after her lumpectomy and sentinel node biopsy, what do you think they are going to get told about radiation and as it pertains to the regional nodes?
Yeah, that's a great question. The NSABP B51 data suggests that there is no local therapy benefit to radiation in patients that start clinically node negative with CN1 disease and then convert to pathologically node negative. That study included patients that underwent sentinel node and patients that underwent AL and D, and is, I think, starting to be more broadly applied, although certainly I will say that there are higher risk features that the radiation oncologists seem to consider, including the presence of residual disease in the breast, the patient's age, the subtype. And so I would probably counsel this patient that there's some data that exists that maybe radiation is not necessary, but I would still be referring routinely to a radiation oncologist kind of in this standpoint, because I think every patient is a little bit different. How about you in your practice, Laura?
Yeah, I think that it's more of a discussion than it used to be, but I think it's still a pretty select group of patients in which it's being offered for omission, and I agree with you. I think, you know, the subtype matters. I think age, people are a little less apt to omit radiation in a younger patient. And then I think also, you know, if this person had 1 or 2 lymph nodes that looked abnormal on their ultrasound versus multiple level 1, 2, and 3 lymph node, you know, what were level 1 and 2 lymph nodes, that might be a different discussion.
Yeah, and I actually think that's something that as surgeons we can do to help our radiation oncologists colleagues with these decisions, to make sure that we're documenting what we think the nodal burden is preoperatively, whether it's via ultrasound or MRI, whatever types of imaging they've had, in terms of, you know, how many nodes, because I do think that's a big consideration in whether or not they're considering radiating, and then making sure we're doing a thorough nodal sampling in these patients that may not be getting additional local therapy.
Yeah, I agree with you completely. And I think the other thing we were talking about this morning in one of the sessions was potentially not doing a frozen section on these patients straight away if they were clinically N0 to begin. So I'm going to kind of flip this case a little bit and say this was a clinically N0 patient and we didn't do a frozen, and then say you got your sentinel nodes back and she had ITCs. What are you going to recommend for the patient as far as local therapy in that setting?
I think for ITCs, we have decent data that suggests that we can omit axillary lymph node dissection. We have the retrospective ICARO study, which was, you know, a large international study and has been published for about a year now. And it's the biggest study we're ever going to have about ITCs in the nodes. So I think that I would feel very comfortable omitting axillary dissection. I think the bigger question is, what about radiation in those patients with ITCs, because ITCs were included in NSABP B51. What's kind of been your experience in your practice, Laura? Are you seeing radiation oncologists consider omission for patients with residual ITCs?
So I think it's probably a little different in the population of patients that were clinically node positive before chemotherapy, in which probably those patients are a little bit more likely to radiate and not apply B51. But I think in a clinically node negative patient, they are having that discussion. And I guess the other group of patients where we get sentinel nodes back, where we're sort of having more discussion around are the patients with micrometastasis. I know we have a group of local therapists here in our audience, so I am going to just ask folks in the audience, if you receive micrometastases back in your sentinel node after patients had neoadjuvant systemic therapy, could you raise your hand if you are doing an axillary lymph node dissection at this point? So for our virtual learners, we have a couple of people that have raised hands, but it sounds like people may be omitting axillary dissection or sending the patients on for radiation if they have micrometastases in the nodes. So Olga, tell me, what are you doing in your practice if you have a patient with micrometastases?
Well, I would say it might slightly depend on that clinical nodal status. I think in the patient that starts as clinically N1 and then has residual micromets and it's on frozen, then I'd probably dissect them. But if it's at final pathology, then I'd probably present it at tumor board and see if, as a group, we felt comfortable just moving forward with radiation. Now, we don't have any level 1 data to support that approach, but we know that in general, we're kind of moving towards radiation of the axilla to control that residual axillary disease. And then there was some data presented last year at SSO, kind of the same group as ICARO, looking at micromets, retrospective international study, that suggested no local benefit except in the triple negative cohort, where there did seem to be some increased axillary recurrence. So I don't believe that paper is out published yet, but I think we still have more work to do before we kind of know the answer to this.
And I think it is a little bit harder to know what to do until we have the data published around the prospective trial looking at this. Hopefully, we'll have some of that soon. Our pathologists sometimes very nicely talk about if there's treatment effect seen in the nodes or fibrosis present. Does that, if you have multiple lymph nodes with fibrosis present and they have some, 1 or 2 nodes with a micromet, would you go back for that?
I probably would at this point in time, just because that's really still the standard of care. But I do think it also depends on, what does the patient think? And I think kind of relaying all the options and just making sure they understand the standard approach versus the fact that in a few years we probably will have data suggesting it is likely safe to omit AL and D, but we just don't have that data yet.
And I think to go along with the treatment effect and fibrosis and things, if we flip towards the breast at this point and we talk about patients having lumpectomy, there's oftentimes we're seeing, thankfully, a little residual live tumor and significant tumor bed or fibrosis in our lumpectomy specimens. Could you talk to me a little bit about how you think about margins in that setting and how you think about it maybe if there's nothing seen versus if there are these scattered residual tumor cells within the tumor bed?
It's a great question. We don't really have a standard in the neoadjuvant setting. We have clear margin guidelines in the upfront surgery setting. I think retrospective studies, including out of, I think, Dana-Farber, Memorial, and a few other institutions, have suggested that no tumor on ink works, and that the local recurrence rates don't seem different if you use a different margin width. And so that's kind of how I've been using these. I will say, though, if there's kind of scattered tumor cells and if they're in multiple margins, then I do get a little bit more worried, and I might consider re-excision if there's a close margin, but not tumor on ink in a situation like that with kind of a scattered approach, because then you have to worry that there might be some more scattered disease in your entire tumor bed, not just what you removed. But that said, we know that we leave small amounts of residual disease behind in the breast all the time in the upfront surgery setting, and so that's what our adjuvant therapies are for. How have you been addressing kind of that small amount of scattered disease in the margins?
Very similar to you, just sort of taking a look at the whole picture and trying to figure out if it looks like we've had concentric disease or if it is more widespread and scattered, whether or not there's a focal margin that needs to be re-excised. Yeah.
Right.
Great. Well, I think we have a lot of great questions that have come up in our chat as well, and we definitely are going to get to as many of those as we can. But what I want to make sure is that we have time to kind of walk through our cases tonight. So I am going to just first pull up the slide and say, ask you, have you changed your mind since you answered our initial polling question? If you want to go back in and answer the question again. We're not going to show the result for this one, but we will ask you to take a moment to do that. All right, and what we'll move on to right now is hormone positive early breast cancer. And so again, we are going to start with a case. In this case, we're going to talk about Sophia. She is a 55-year-old postmenopausal woman who was diagnosed with a hormone receptor positive breast cancer. She presented with a palpable mass in the right breast, and her axillary exam was negative. When she underwent breast imaging, she was found to have a 4-centimeter mass, and on core biopsy, this revealed a grade 3 invasive ductal cancer, ERPR positive, HER2 negative, Ki67 of 20%, and an oncotype was sent on her core, which was 30. She had an axillary ultrasound revealing a single 1.3 centimeter axillary lymph node with a 4 millimeter cortex, which underwent a fine needle aspiration and was negative. She did have staging with PET-CT, which was negative, as well as genetic testing, also negative. And she subsequently had upfront surgery with a right mastectomy and axillary surgery performed, revealing a 4.3 centimeter grade 3 invasive ductal cancer with 2 of 3 sentinel nodes positive. So again, as we discuss the data here, we'd like you to think about what you would do next. So the question for this case, what systemic therapy would you recommend to Sophia? And as a reminder, she has a 4.3 centimeter grade 3 invasive ductal cancer. She has 2 of 3 sentinel nodes positive and an oncotype of 30. So number 1, adjuvant aromatase inhibitor. Number 2, adjuvant abemaciclib plus an aromatase inhibitor, but no chemotherapy. Number 3, adjuvant ribociclib with an aromatase inhibitor, but no chemotherapy. And number 4, chemotherapy with an adjuvant CDK4/6 inhibitor, abemaciclib or ribociclib plus an aromatase inhibitor. Or 5, I'm not sure. All right. The oncotype of 30 was a good cue. So I'm going to invite Kamel back up to speak about the evidence we have for these decisions.
But I'm going to start by saying that I'm really impressed. We have a very smart group. They're ready to become medical oncologists. I'm not sure any medical oncologist can fulfill the place of a breast surgeon, though. All right, so talking about hormone receptor positive, our most common subtype. And this is always a tricky algorithm to create because there is the premenopausal, postmenopausal, lots of variables, and the oncotype that really dictates in what direction we should move. But if we look at it from the nodal involvement, so for node-negative disease, I think we all agree that for the Taylor X trial has really set the standard here. So for the premenopausal patients, if they have a score less than 20, then most of the time they'll be able to avoid chemotherapy and go on to endocrine therapy. Postmenopausal patients, if they score less than 26, then they proceed also with endocrine therapy alone with omission of chemotherapy. Just a little hint, we usually use another tool called RS-CLIN that takes into account other features, including the grade of the cancer, the size of the cancer, the age of the patient, that really helps us further refine the result that we get from the oncotype report. What about 1 to 3 positive lymph nodes? Now, those are patients where we draw a lot of the conclusions from the RxPonder trial that basically showed us that postmenopausal patients, if they score less than 26, they can safely omit chemotherapy and proceed with adjuvant endocrine therapy. And of course, this is with or without CDK4/6 inhibitor, and we'll talk about that. But for the premenopausal patients, we've seen from that trial that any premenopausal patient with any form of nodal involvement really did benefit from chemotherapy. So typically, those patients will proceed with chemotherapy followed by endocrine therapy. A very important trial that we will look at also is the offset trial that is trying to answer whether chemo is needed in this population or not. And then our very high-risk patients, so patients that have 4 or more positive lymph nodes, those are patients that will all receive chemotherapy typically in the preoperative setting and then proceed on with surgery, and then after that, endocrine therapy and CDK4/6 inhibitor. So again, the same concept. Drugs that work well in the metastatic setting, they always move to the early stage high-risk setting. So we've seen the 3 CDK4/6 inhibitors, palbociclib, abemaciclib, and ribociclib being tested extensively in phase 3 trials. The first 2 trials, which are Penelope-B and Pallas, are both testing palbociclib, one for 1 year, one for 2 years. Those 2 trials were negative, so we're not going to focus on those. The ones that we will talk more about are the Monarchy and Natalie. The Monarchy trial, which is a phase 3 trial that looked at high-risk node-positive disease and offered them adjuvant abemaciclib in addition to their endocrine therapy for 2 years at the standard full dose. And the Natalie is another trial that included high-risk hormone receptor positive, node positive, and some high-risk hormone receptor positive, node negative patients, and offered them dose-reduced ribociclib for a period of 3 years in addition to their standard of care endocrine therapy. Both were positive trials. In ESMO of last year, we saw the 7-year update from the Monarchy trial with impressive improvement in invasive disease-free survival and distant recurrence-free survival. So the primary endpoint, IDFS, we've seen that the delta between the two curves keeps separating and keeps getting larger over time, telling us that the benefit is consistent and improving. And we've seen the delta here is about 6.9% at 7 years with a hazard ratio of 0.73. Distant recurrence-free survival, which in my opinion is a very influential endpoint, and this is so vital because God forbid if the patient becomes metastatic in a distant site, this is when they become incurable and they're committed to treatment for the rest of their lives. So here we've seen the same level of benefit with an improvement in the delta over time over 7 years, delta 5.5% with a hazard ratio of 0.73. So we can tell patients that there is a 27% improvement in the chances of recurrence from the addition of 2 years of abemaciclib. OS data, for the first time, we were also able to see that there was a difference of about 1.8% in the ITT population, 2% in the cohort number 1, which is the largest cohort of the trial, and that came with a hazard ratio of 0.83. This is the holy grail of medical oncology, so nobody can deny that there is a meaningful benefit from such an intervention. The other trial, Natalie, that used ribociclib, and here we've seen the 5-year data with a delta of 0.5% in IDFS with a hazard ratio of 0.71. When it comes to other endpoints, including distant disease-free survival and distant recurrence-free survival, we also have seen very similar delta of 4.3% with a meaningful hazard ratio. The OS data is still immature at this point, but definitely moving in the right direction with a hazard ratio of 0.80, but still, only time will tell here. Now the question of IO therapy, does it have a place in treatment of hormone receptor positive breast cancer? And we have 2 large trials that announced some initial results. The year before last year, those are the Keynote 756, which is a trial that looked at patients with hormone receptor positive high-risk disease, and those are patients that, as you can see here, T1C or T2, N1 to N2, or having very large tumors, T3 to T4, and those patients were grade 3. What they did is they treated them either with acetaxol or acetaxol plus pembro. And here you can see that there was an improvement in PCR rate from 15.6% to 24.3%, so a delta of 8.5%. Now, this trial is also powered for event-free survival. We don't have that data available yet, and that is what we're waiting for. For the Checkmate 7FL, this is another high-risk hormone receptor positive early-stage trial that looked at patients with grade 3 cancer or grade 2 with low level of ER expression, so up to 10%. Those are the low expressors, the triple negative like patients with very high risk, and here they used nivolumab in addition to chemotherapy. And here again, we've seen an improvement in PCR rate with a delta of 10.5%. So very promising for this high-risk population. Now the story of oral SERDs, and oral SERDs are really extremely beneficial endocrine therapy that, in contrast to our AIs that decreases the amount of active estrogen, or our tamoxifen that blocks the receptor, those molecules, the selective estrogen receptor downregulators or degraders, they destroy the receptor. They're very effective. They are being studied extensively in the early stage, high-risk setting, in the adjuvant setting. The one trial that resulted in San Antonio of last year is lidERA trial that tested one of those oral SERDs, giredestrant, for 5 years. And I'm going to show you in the next slide how impressive the results were. Actually, let's take a look at it right now. Here you can see that this analysis only happened early on, a little over 2.5 years. And you can see that the curve separated nicely with a hazard ratio of 0.7. So there was a 30% improvement in risk of recurrence. And you can see that the benefit was more apparent in patients that received tamoxifen compared to patients that received AI. So we are hoping that this is going to have an FDA approval. We're going to get regulatory approval and be able to use that for patients with medium risk or high risk disease. But there's a lot of trials that are deploying a similar strategy in a way. So many trials, including Cambria-1, Ember-4, and Elegant, are giving patients 2 to 5 years of their standard endocrine therapy with or without a CDK, and then randomizing them to either continue with the standard of care AI or tamoxifen, or go on to an oral SERDs, whether it's camizestrant in Cambria-1, imlunestrant in Ember-4, and elacestrant in Elegant trial. Or in Cambria-2, you can see that patients are randomized right away after surgery to going to camizestrant with or without abemaciclib versus the standard of care endocrine therapy. Now, the OFFSET trial, which is a trial that is exploring, is it truly the chemotherapy that is benefiting our young, high-risk patients or not? So basically, this is a trial that is looking at premenopausal patients with hormone receptor positive early stage disease that are either node positive and having an oncotype up to 25, so those are patients that typically would get chemotherapy in our clinics, or patients that are node negative and have an oncotype of 16 to 20, provided they have a high clinical risk, and that is defined by having a large tumor, more than 3 centimeters or grade 3, or having an oncotype that's high, so 21 to 25. And what they are doing here, they are randomizing patients 1-to-1 to either receiving standard of care chemotherapy, followed by ovarian function suppression and an AI for 5 years, or just the ovarian function suppression and AI for 5 years. They're trying to answer, is it the immunosuppressive, or sorry, the ovarian suppression that happens from the chemotherapy that benefits those patients, or is it the chemotherapy itself? Perfect. Right on time.
Great. So we're going to go into a case discussion. First, let's review our case of Sophia, 55-year-old postmenopausal woman who is diagnosed with hormone-positive breast cancer. And she had come in with a symptomatic mass in the right breast and negative axillary exam with 4-centimeter mass seen on breast imaging, the core biopsy revealing a grade 3 invasive ductal cancer, ER/PR positive, HER2 negative, Ki-67 20%, and oncotype of 30. The axillary ultrasound had revealed a single abnormal node with a 4-millimeter cortex, but fine needle aspiration was negative. She did have negative PET-CT staging and negative genetic testing, and she had undergone right mastectomy with axillary surgery to reveal a 4.3 centimeter grade 3 invasive ductal cancer and 2 of 3 sentinel lymph nodes positive. So what we're going to do is consider what we would do next and what treatment options should be considered. So what I'd like to discuss maybe first is, for both of you, this patient, high oncotype, large tumor, suspicious node, but it's FNA negative. Is it always the case that you want to have upfront surgery for this patient, or when would you consider neoadjuvant systemic therapy, and what type?
Me or Olga?
Both of you.
Okay, perfect. No, I really don't have a must-do path for each patient. I think it's a case-by-case discussion. For us, I think it's always nice to have more accurate details from surgery about the nodal status, and that really does impact our choices for systemic therapy in the post-operative setting. So it's a discussion with the surgeon, and many times I ask them, is that going to make a difference in the surgical planning in terms of management of the axilla, in terms of where the cancer is located, and whether we have any problems getting negative margins, and that's going to drive my decision, really.
So for this patient, Olga, with hormone-positive breast cancer, what's your thinking about the likelihood of preoperative systemic therapy downstaging either the breast or the axilla?
So I think in terms of downstaging the breast with a 4-centimeter tumor, we're probably going to be pretty successful in doing that with some kind of neoadjuvant therapy. This patient has a high oncotype, so probably chemotherapy makes the most sense since we know she's going to get chemotherapy anyway. I think the medical oncology question is maybe how much chemotherapy, and sometimes the nodal information helps with that. And so that sometimes our oncology colleagues don't, ideally would want to give it in the adjuvant setting to help tailor that decision. For the nodes, in a case like this, I think with one suspicious lymph node, they're actually more likely to, they're not likely to downstage in the setting, their axilla is not likely to downstage. We know the PCR rates in these cases are maybe 10 to 20% at most. And so if we take her down a neoadjuvant chemotherapy pathway, and we're highly suspicious of the nodes, or if we know a node is positive, she's probably going to get a dissection, because right now the standard of care is to dissect someone with residual disease. But in the setting of someone like this that seems like they have a low nodal burden, I think we could consider applying like a Z11 Amorose approach. It's just we only saw the node on imaging. She's clinically node negative by palpation, and so can we just kind of start with the sentinel node and then let the pathology guide us?
Yeah, I think that's how I'd probably approach that, because I agree, there's not a huge benefit to downstaging the breast oftentimes when it's a moderate-sized tumor, and for the axilla, it's just unlikely it's going to happen. I totally agree with the idea of approaching as per Amorose if we're going in with a clinically node negative situation where the FNA was negative. So what if I say that the FNA was positive and that there was a single abnormal node on the ultrasound, and we said the exam was negative? What are you going to do with the axilla then if you're doing upfront surgery?
So I'd still approach it with like a Z11 Amorose approach, although since we know that she's starting with at least one positive node, I think the likelihood of a dissection is higher, so I do counsel patients on that. But there's kind of a whole slew of retrospective single institutional data that suggests in the setting of just one or two abnormal lymph nodes on axillary ultrasound and clinically node negative by palpation disease, the likelihood of a lower nodal burden, only one or two positive nodes in these patients that all had ALNDs and were looked at retrospectively, is about 60-65%. So a lot of these patients have a low nodal burden, and I think we'd all feel comfortable, if we didn't know about that positive node, because we hadn't imaged it, then we would feel very comfortable omitting ALND, and so I think we can apply that same approach. I think in someone with 3 or more positive nodes and a biopsy-proven node, I'd probably go straight to ALND, or more strongly consider a neoadjuvant approach to, at least give her that 10 to 20% of downstaging the axilla.
So I think, I always think about these patients who have an ultrasound that's abnormal and an FNA positive node. When I'm doing the sentinel node up front, I'm always worried that I'm not going to be able to tell which one it is, because presumably we're saying it feels pretty normal. So do you, aside from using the dual tracer and trying to get, a bigger sample size, do you do anything to target that node if you're doing an upfront sentinel node for someone who has a single positive node?
Yeah, it's a great question. I think you can approach it either way. In someone that hasn't had any neoadjuvant therapy, it should be the sentinel node, right? Because it's the node that's positive. That said, I have personally had a case where that wasn't the case. And so I do think clipping the node or marking it or localizing it in some way is very reasonable. But I would say most of the time you're going to get it with just kind of a routine dual tracer sentinel node and a thorough sampling.
Yeah.
What's been your practice?
So I am a risk-averse human being, so I tend to just I don't necessarily clip it ahead of time, but I definitely, if upfront surgery setting, I'll localize it going in. And just Thursday, I was glad that I did that because it wasn't a sentinel node. So I think that it is always likely that you're going to feel it or that it's a sentinel node, but I hate to commit someone to a dissection, say, if I don't get that one, and then it's hard to find.
Laura, what about in the setting of one abnormal node, but it's palpable?
So and if it was FNA positive?
FNA positive. Would you consider this approach, or would you go straight to ALND?
So we learned this morning, right, that there wasn't a difference in additional positive nodes. One of the presenters this morning was talking about this and stating that there was not necessarily a difference in the likelihood of significant additional positive nodes if it was palpable or not. That didn't come out in their analysis, and I was happy to hear that because I personally have been offering patients with a single palpable node that is a little bit prominent but not grossly abnormal, a sentinel node in that setting. How about you?
Yeah, I think if it's a small node in a skinny patient and like that's the reason you can feel it, versus, if someone presents with like a 3 centimeter giant lymph node, I'm probably not gonna necessarily approach it in the same way because that's not really the spirit of Z11 and Amarose.
Yes, agreed. So this patient is postmenopausal. If we were to make her oncotype 5, and knew she had a positive node from FNA, she got 6 months of NAI. Would you offer her a sentinel node knowing that she had a positive node to begin with? And if it was still positive, what would you do with that information?
Yeah, great question. I think this is kind of an area we don't really have a lot of data, but I really think of the management of the axilla and neoadjuvant endocrine therapy like the same as in the upfront surgery setting, because these patients have only had like a fraction of their systemic therapy and they have a lot more adjuvant therapy to go. So I'd approach it the same way, starting with the central node, probably like a targeted axillary dissection, making sure that probably would maybe clip that node in that case, just to make sure it comes out, and then kind of go by the final pathology to determine whether or not she gets an ALND. If it was just 1 or 2, I'd just do the central node. If it was 3 or more, I'd dissect her.
I'd do the same, yeah. And one thing I want to make sure we have a moment to talk about, because we've gotten some questions about it too, is back to you, Kamel. Talk to us about ctDNA, liquid biopsies in a higher risk patient.
Yeah.
Are we using it? How are we using it? What should we be doing?
Yeah, it's the $1,000,000 question. I think ctDNA, or circulating tumor DNA, is a very robust biomarker for disease recurrence. And that really applies to all different subtypes of breast cancer. Definitely the pattern of shedding or the amount of ctDNA positivity is much higher in cases like triple negative breast cancer compared to hormone receptor positive breast cancer, just by virtue of the biology of the cancer and patterns of shedding overall. So having said that, it is a very strong prognostic biomarker, and the fact that it has 100% positive predictive value after surgery. So if the patient had surgery and they have a positive ctDNA, there is probably 100% chance that they're going to recur. The median lead time is more than 370 days, so more than a year. So we don't know exactly when the recurrence will happen. What is lacking is we don't have any ctDNA-guided intervention, therapeutic intervention, that has promised us a chance to alter that unfortunate recurrence event. And that is why ASCO right now is recommending or not recommending routine use of ctDNA outside the scope of a clinical trial. So we do test a lot of patients under the umbrella of clinical trials, but outside of that, it is a rare occurrence that I would do it, except in very few situations where I feel that it is the right scenario with the right patient who fully understands that, so that it doesn't cause unnecessary anxiety for both us and patients. And one last thing I tell patients is, yes, it's going to be quite informative in terms of prognosis, but we cannot escalate therapy based off of that.
All right, I have 2 quick shot questions. You each get 1-word answers. Olga, T2 N0 cancer, taking them to the OR for mastectomy, frozen section on the nodes, yes or no?
No.
Okay. Kamel, we do this surgery. You have 2 positive sentinel nodes. You're trying to decide on a CK4/6 inhibitor. Do you need an axillary dissection to have the other nodes to decide?
For this patient, no. She has criteria for both. Yeah.
In any patient, do you?
Is there a patient where I would need? Rarely nowadays, after the approval of ribociclib, we feel that we just want to give them a CDK. We don't really feel strongly about one or the other.
Perfect.
So it's really not an issue right now.
Great. Thank you. Sorry, I made you say more than one word. All right, so we're going to return to that question that we asked at the beginning of this case. If you go ahead and go back in and answer the poll again, we are going to move on, but if you'll just please take a moment to answer that question. Our third topic for tonight is going to be HER2 positive early breast cancer. So again, we're going to start with a case. This case is going to be Amelia. She is a 57-year-old healthy woman who's diagnosed with a HER2 positive breast cancer. She was called back for a screening, from her screening rather, for an asymmetry seen in the left breast. On her diagnostic imaging with mammogram and ultrasound, she had a 1.7 centimeter mass in the breast, and her biopsy revealed a grade 3 invasive ductal cancer. It's hormone negative, HER2 2+ with a positive FISH. And she had an ultrasound of her axilla that revealed 2 abnormal nodes with 5 millimeter cortices, and her fine needle aspiration was positive for malignancy. And so again, we're gonna see what you would do next. So what would you recommend for Amelia as next steps? Reminder, 1.7 centimeter, grade 3 IDC, HER2 positive, hormone negative, with 2 abnormal axillary nodes, which were FNA positive. Number 1, surgery with lymph node dissection, and then give adjuvant HER2 therapy, no T-DXd. 2, neoadjuvant anti-HER2 therapy with chemotherapy, then surgery, and use HP, trastuzumab and pertuzumab, if a PCR is achieved. Number 3, neoadjuvant anti-HER2 therapy with chemotherapy, then surgery. Consider T-DXd if residual invasive disease remains. And 4, neoadjuvant anti-HER2 therapy with chemotherapy, then surgery. Use TDM1 if residual invasive disease remains. And number 5, I'm not sure. All right. This was definitely the trickiest question, I thought. That we have our answers here, and we'll see what we learn. So, Kamel, if you want to come up and teach us about HER2 positive breast cancer.
Perfect. All right, so this is the subtype that probably has seen a lot of change in the last few months. So to start off, the schema is not easy because it is about to change a lot. And I would say that what is not present here is the very early stage, so stage 1 disease, so patients who have less than 2 centimeters of cancer, node negative. I think all of us agree that the APT regimen with Herceptin Taxol for 12 weeks, followed by maintenance Herceptin, has set the standard and is so beautiful in terms of disease recurrence, free survival, even at 10 years, more than 90%. But moving on to the more locally advanced. So at the top here, we have stage 2A disease. And I think we've learned from a lot of trials that we can safely omit carboplatin for this very low-risk population and get away with THP for 4 cycles. And then after that, patients would proceed with surgery. And based on whether they achieve PCR, where they will continue with anti-HER2 therapy, or they have residual disease, where the standard of care has been set by Catherine trial using adjuvant TDM1. The second bullet here is stage 2B, so a little more advanced, and right now the proposed regimen is to give them THP, so without carbo also, 4 cycles, and then repeat an interval MRI. And if we are having a radiographic CR, and this is hormone receptor negative, so the chances of getting a pathologic CR is very high, then move on to surgery and follow the same path. If this patient is having near radiographic CR, then probably giving them 2 more cycles, so a total of 6, makes perfect sense. And if the patient is having clear residual disease, then probably with the new data, consider giving them 4 cycles of T-DXd. And we're going to talk about that in a second. So I forgot to mention that in this algorithm here, everything that has a dotted line is not approved yet, but this is what we're hoping will change in our guidelines very soon. For more locally advanced disease, so stage 3, right now we do give those patients 6 cycles of TCHP and follow the same path. But the alternative regimen, which was set by the Destiny Breast 11, is 4 cycles of TDXD followed by 4 cycles of THP, and then move on to consider adjuvant therapy, which now has a competition to TDM1 with the introduction of TDXD. So let's see the data. So here, Catherine trial, which has been a paradigm shift for us many years ago, or I should say like a few years ago. And basically, this is a trial that looked at locally advanced disease that received neoadjuvant systemic therapy and ended up with residual disease. And here we've seen the 7-year update from that trial for invasive disease-free survival with an improvement from 67 to 80%. This 13.7% delta with a hazard ratio that was 0.54. Not only that, but we've seen also 7-year OS data with an improvement from 84 to 89% with a hazard ratio that is 0.66, so about 4.6% delta difference. And that really has set the standard for us. However, Catherine trial, as much as it improved overall survival, but still 7% of our patients ended up with the most dreaded outcome, which is CNS metastasis in those early stage disease. And that is the most feared outcome in that disease. So we have here the results of the Destiny Breast 05, which is basically a trial that is designed for very high-risk patients. So when you see the inclusion criteria here, those are patients that have T4 or with any N involvement, or T1 to T3 with significant nodal involvement. About 50% of those patients were deemed inoperable when they were included in the trial, so extremely high risk. And those patients received their neoadjuvant systemic therapy, and instead of being offered TDM1, they are comparing TDM1, according to Catherine, with TDXD. Same number of cycles, so 14 cycles. And here we've seen in ESMO, the results led to a delta of 8.7% at just 3 years with a very significant hazard ratio of 0.47. So that is likely going to challenge the standard of care. More than that, this trial also had other secondary endpoints, including distant recurrence-free interval, and here you can see there was a delta of 7.8% at 3 years. Another one was brain metastasis-free interval. So here you can see BMFI, and that numerically was improved in the TDXD arm. And we've seen also OS, which is numerically improved, but it's still very immature. It's only 2.9% maturity rate. But things are definitely moving in the right direction. In regards to side effects, both TDM1 and TDXD have their own side effects. We've used TDM1 for many years now. We know that it causes elevation in liver functions, a decrease in the platelet counts, can lead to neuropathy, fatigue. When it comes to TDXD on the blue side here, you can see that the most significant side effect is nausea. More than 70% of our patients are nauseated from this medicine, but we've become very good at managing that with the 3 or 4 drug anti-nausea medicine. We also have seen that ILD risk on that trial was 9.6%. So in line with what we've seen in prior trials, 10 to 15% risk of ILD. And unfortunately, 2 patients, so 0.2% of the trial population had high-grade ILD and died from ILD. A very pertinent question to local management, to breast surgeons, and even more relevant to radiation oncologists is, what do we do with radiation? Is it safe to give radiation with TDXD or not? And on that trial, they explored both sequential and concurrent radiation with TDXD with no differences in the adjudicated drug-related ILD. So that's very reassuring. Now, the other trial tested the same drug, TDXD, in the neoadjuvant setting. Also included an extremely high-risk population, so those are patients that have more than T3 with any nodal involvement, or up to T4 with any nodal involvement, and even included inflammatory breast cancer patients. And here they had 3 different arms. They had one arm of 4 cycles of T-DXd followed by 4 cycles of THP, another one which is 4 cycles of dose-dense AC followed by 4 cycles of THP, which is the standard of care like our TCHP here in the US. This is the standard of care in Europe. And the third arm was an all T-DXd for 8 cycles. That last cycle was closed earlier because, as you can see here, it performed less favorable than chemotherapy. So we're going to be focusing on the first 2 comparisons. And here you can see T-DXd and THP, and this is the chemo arm, doing better in terms of PCR. The PCR rate went from 56 to 67% in the ITT population, so a delta of 11.2%. When you break it down by the hormonal status, I think we all agree that hormone receptor negative has a more likelihood of achieving PCR, and here we see that the PCR rate went up to 83.1%. Quite impressive. And the hormone receptor positive also had a delta of 9.1%, but this is a delta of 16.1%. Now, what was good and reassuring about this trial, it's only 4 cycles of T-DXd followed by the chemotherapy, and here the ILD risk, when they compared it in the 3 different arms, you'll see that the T-DXd THP arm only had 4.4% ILD, and even the chemotherapy alone arm had more ILD than that, 5.1%. So quite reassuring. Now here's the question. So please take that poll. Assuming that T-DXd becomes available for our high-risk HER2-positive early-stage breast cancer, what do you think will be the biggest practice challenges or barriers to implementation of that strategy in your practice? Number 1, perioperative pathway redesign, so timing to surgery. Number 2, safety readiness in terms of ILD pneumonitis management and monitoring. Number 3, eligibility and sequencing clarity. Number 4, axillary and localization logistics after neoadjuvant therapy, or all of the above. Please vote. All right, so we see a smattering of answers, but I think a lot of people are voicing concerns about all the above. So again, the story of IO or immuno-oncology in HER2-positive disease. Till now, we don't have any clear signals of benefit in the neoadjuvant setting from all the prior trials, but this is an ongoing trial, a Stefania trial, that is exploring the use of adjuvant anti-PD-L1 atezolizumab in addition to T-DM1. So for our patients that receive neoadjuvant systemic therapy and end up with residual disease, instead of getting T-DM1 alone, it's adding atezo to T-DM1, and the primary endpoint is IDFS. Those are 2 very important trials, and those are the COMPASS trials. So the COMPASS trials, first one is phase 2 COMPASS HER2 PCR. And it's basically treating patients with a short regimen of THP for 4 cycles, so only 12 weeks of carboplatin-free regimen, just THP. And then the patients that achieve PCR, it's going to follow them up for 3 years to detect the endpoint here, which is recurrence-free survival. So not only are we focused on achieving that beautiful endpoint, but we want to make sure that patients who achieve PCR from 4 cycles of THP are going to continue recurrence-free for the next 3 years. This trial is also showing us some benefit of another biomarker called the HER2-DX. HER2-DX is like our Oncotype DX for hormone receptor positive disease, and we've seen here a positive correlation with having an intermediate or high HER2-DX and the chances of achieving PCR. The second trial is COMPASS HER2-RD, so the COMPASS HER2 for residual disease, and that is a trial that is trying to fix something that we've seen from the Catherine trial, which is the brain metastasis. So any patient who receives neoadjuvant systemic therapy and ends up with residual disease, instead of offering them TDM1, it's adding an oral small molecule TKI, or tyrosine kinase inhibitor, to catinib, which we use extensively in the management of metastatic HER2-positive cancer, in the hope that we can decrease brain metastasis. Now, last but not the least, I had to point out to a surgical trial, the Exceptional Responders trial, and this is a trial that is looking at, it has multiple different cohorts, but I wanted to bring up the cohorts that are focused on triple-negative breast cancer or HER2-positive breast cancer who have T1 to T2 N0 disease or up to N1 disease. And those are patients that got treated with neoadjuvant chemotherapy and were able to achieve radiographic complete response. Those patients undergo multiple core biopsies, at least 12 biopsies, to confirm that there is no residual disease, and then they could potentially omit the surgical approach to the breast. We have seen last year the updated 5-year follow-up from the phase 2 trial, and it showed us that out of the 50 patients, 31 were followed on the trial that had negative biopsies, and we've seen over 5 years ipsilateral breast recurrence 0%, and the recurrence-free and overall survival is 100% for 5 years. So really quite impressive. All right, perfect.
Thank you. So we're going to go back to our case discussion here. Amelia, our 57-year-old healthy female diagnosed with a HER2-positive breast cancer. She had a screening abnormality on her mammogram with an asymmetry seen in the left breast. On diagnostic imaging was confirmed to be a 1.7 centimeter mass, and the biopsy revealed a grade 3 invasive ductal cancer, hormone negative and HER2 positive, with ultrasound of the axilla demonstrating 2 abnormal nodes with thickened cortices, and FNA was positive for malignancy. And so as we consider treatment options for this patient, we're going to walk through a few different scenarios here. So I think one thing we've been getting a number of questions about is just thinking about the size of a cancer and how that influences the decision to manage them with 12 cycles of TH in an adjuvant setting versus thinking that they really would benefit from the neoadjuvant systemic therapy. And so if you say have someone with T1C clinically node negative disease, I guess, Olga, maybe for you, what are you doing imaging-wise, or how are you sort of assessing to make sure they are, in fact, clinical stage 1? MRI, ultrasound?
Yeah, I think for these HER2 positive and also for triple negative T1Cs, it's just kind of important to help understand which patients might actually have some subclinical nodal disease. And so I am pretty routinely getting axillary ultrasounds, although an MRI is probably sufficient. So some kind of like more detailed axillary imaging to ensure that we're not missing non-palpable disease, because that would put them down like a much clearer neoadjuvant pathway.
Yeah, I think there's a suggestion that maybe even up to 15% of patients who are T1C might end up having an abnormal ultrasound or nodal involvement when you screen that way.
Yeah, exactly.
And so I think the other challenge is if they were 2.1 centimeters, you would call them stage 2 and potentially give them neoadjuvant. What if they're 1.8? Like, are there factors that would prompt you to feel like that patient might benefit more from that approach?
Yeah, it's a gray zone, and again, the APT trial did include a small number of patients that were more than 2 centimeters. But again, we feel comfortable for patients that are less than 2 centimeters and node negative to go to surgery first and then giving them their adjuvant therapy. Not only that, but we've seen also the ATTEMPT trial that looked at TDM1 for a whole year with very comparable efficacy, if not even higher than APT. But I think it's a discussion, and one very important factor that I did not bring up also is sometimes patients have a larger disease, but they have a lot of comorbid conditions that prohibit us from giving them something like TCHP or a more intense therapy. And for those patients, we tend to treat them even in the neoadjuvant setting, but with TH sometimes, with very good results in some patients. So yeah, I think it's not an easy, straightforward answer.
For sure. And I think one thing that's kind of come up as we were talking through in the algorithm you presented was MRI. So Olga, talk to me about how you use MRI for these patients. Do you routinely? When do you get it?
Yes, another great question. So I think I will say in patients going down a neoadjuvant pathway, I'm more likely to use an MRI than maybe in patients that are going straight to surgery. That said, we had some nice data presented at San Antonio this past December that suggested that use of preoperative MRI in both HER2 positive and triple negative disease doesn't change local regional outcomes, and so then that kind of tells us that maybe we're using too much MRI in these patients. But I do think MRI can be helpful for surgical planning, especially in patients that start with like really large tumors, to kind of get a sense of whether or not they're going to be candidates for breast conservation. So at least in bigger tumors or in patients with multiple sites of disease, I think MRI kind of preoperatively and then again towards the end of treatment is helpful to help guide those surgical decision-making decisions. The algorithm presented is kind of interesting because then you're not really getting that MRI necessarily like right at the end of treatment, and so it may not give you the full clinical picture. How set in stone is that for 4 cycles in MRI regimen?
Yeah, it's new. I don't know that I implemented in my practice, but we talked about this sort of an adaptive approach, basically, in order to get a quick sense, and it's very, very helpful in the higher risk patients with stage 3 when we are thinking about including TDXD. So I think a lot of us are hoping that we can start with THP. In the beginning, the trial started with TDXD followed by THP. So a lot of us are hoping that we can start with THP in order to see if we are getting a significant radiographic response, and then add TDXD or not based on what the MRI is showing. But it's not set in stone. Yeah.
I think the other place that I sometimes think about the MRI, particularly for HER2 positive and triple negative, are those patients we were talking about that are that T1C kind of right on the border. I feel like sometimes it's helpful to get the MRI just because it may provide a little bit more information about the fact that they may look more like a T2 than a T1.
They always do.
Yeah.
They always do. Yeah.
It's a good way to give systemic therapy preoperatively if you want to.
Also, I might just add, last month we had a report from the TRAIN3 trial, which is a Dutch trial that looked at HER2 positive breast cancer, and it showed that in the hormone receptor negative HER2 positive subset, about 30% of the patients on the trial after 3 cycles of TCHP had this complete radiographic response, and they went on to surgery, which confirmed the presence of PCR. So reassuring. Yeah.
And then I think the other thing in this case that from a local therapy standpoint, I wanted to kind of talk about a little bit is you mentioned in the last case, Olga, clips and axillas a couple times. So talk to me. This patient had 2 abnormal nodes. They had a biopsy. Do you want clips in their lymph nodes? What's the benefit? When do you want them?
Yeah. So I think the data overarchingly says that it doesn't really matter whether you clip nodes or not as long as you do a good nodal sampling. And, but I think institutions have decided. So if you're an institution that clips, I would clip to make sure that you're having a good sampling, and then I'd localize that node. And then if you're an institution that doesn't clip, then I think you just want to really try to optimize decrease that false negative rate by using dual tracer and trying to get 3 sentinel nodes when you're doing your nodal sampling, but the outcomes data is completely equal. So I don't think one approach is better than the other. I am coming from an institution that used to not clip, and now I'm at an institution that does clip. So I personally feel comfortable with both approaches.
Yeah, I think the only thing that clipping introduces is sometimes some technical challenges with both the identification of the clip node after someone's had a nice response to therapy, the technical piece of localizing it, the displacement of both clips and localizers. So how much, if there is a node that's clipped that you don't get, do you try to identify and find it if there's a technical mishap?
Yeah, that's a great question. I think that's kind of a case-by-case basis depending on whether or not you feel like the clip was in good position, if it was truly marking the positive node, if there's treatment effect, or if they can tell you that maybe on your frozen, then you know that you've gotten a node that was positive before. So I think I would typically not dissect at the time of the surgery and then kind of use all of that information to make a final decision at the final pathology. And also kind of discussing with the patient their risk tolerance, because if you've done a good nodal sampling and you don't get the clip, like it's probably still okay, especially if you have treatment effect in other nodes, and especially if the patient started with more than one suspicious node. But if it was just one, and it was definitely the clipped one, and you definitely didn't get it, and the clip is still there, then it becomes a little bit more challenging, and sometimes you feel obligated to go back, especially if it's gonna be the only site of potential disease, and then that completely changes the systemic therapy algorithm. What's been your
Same. I
guidance on
feel the
that?
same. I think it's a challenge, and I think it is looking at the whole picture, trying to discuss it at tumor board if there's a question, and just seeing what the potential systemic therapy implications are of having that information. Yeah. Great. Well, let's move back to the polling question we asked initially. If we're not going to show the answers, but if you'll just take a moment to go back in and follow up on this one. And going to just have you answer again, in which of the following areas was today's educational session most helpful to you in guiding your practice now and in the future in early stage breast cancer? Number 1, coordinating multidisciplinary care like imaging, systemic therapy, timing, pathology. 2, optimizing surgical planning and axillary management. 3, selecting and integrating systemic therapy advances into surgical pathways. 4, postoperative response assessment to guide adjuvant therapy decisions. And 5, I received helpful guidance in all of the above areas. Great. So looks like we had a successful session. But we do have a few minutes here to try to answer some of the questions. If you do have additional questions, please go ahead and scan the QR code there. And I know we do not have a ton of time, but one thing that's come up in a number of the questions we have is sort of around some of these newer therapies, the IOs, some of the CDK4/6 inhibitors, the PARP inhibitors, and surgical complication risk. I know we talked a little bit about stopping pembrolizumab about a month before surgery, but I guess I would ask you, are there other surgical complications that we need to be thinking about for patients who are on some of these newer drugs? And then I'll ask you, Olga, just as far as like what you think about for timing of patients for things like second stage of reconstruction, those sorts of things, if they might be on a PARP inhibitor, they might be on TDXD.
All the molecules that we talked about, whether they are CDK4/6 inhibitors or PARP inhibitors, they're all in the adjuvant setting. So hopefully those won't interfere with surgical planning at all. For chemotherapy, I think we're all familiar with the standard of care. TDXD, I think the one important piece is impact on the radiation timing, if that is used in the adjuvant setting. If used in the neoadjuvant setting, which by the way is not FDA approved yet, I don't know that there is any concerns except just the usual monitoring of ILD.
So I think the main, like in terms of the surgical piece, it's really for kind of second stage recon and like additional, cosmesis optimizing surgeries that patients would be getting during their adjuvant therapy. And so I think it does come up. I've had a few cases of, patients on PARP inhibitors for ovarian cancer that then get breast cancer, and then we have to think about, do we have to pause that perioperatively? And I believe that you do have to pause it, although it seems like it's a short pause.
It is, yes. But the most common side effect is cytopenia, so we usually have to pause for at least 1 to 2 weeks.
Yeah, and then I haven't come across, at least personally, like the CDK4/6 interruption, but that would become an issue with the plastic surgeons.
Exactly.
Do you have to pause that?
I do, because we've noticed in our institution that there are issues with wound healing when the patient is on CDK4/6 inhibitors in the adjuvant setting. So right now we stop it for 1 to 2 weeks also. The difference in the neutropenia that happens from CDK and chemotherapy is that it really takes a short time to correct itself, because it's not a myelosuppressive or a cytotoxic effect, it's a cytostatic effect, so it just puts a pause, so it reverses itself a lot earlier.
And when do you pause it 1 to 2 weeks pre-op and then start again 1 to 2 weeks post-op?
That is correct.
So it can be up to about 4 weeks of interruption?
Pause. Yeah.
Great. Well, I know we are right at time, and I want to thank everyone for submitting the great questions, and thank both of you for the great discussion tonight. Sorry, I went too far. So I want to thank you all, both in person and virtually, for joining us. After this session is concluded, you can scan the QR code or visit PeerView as seen here to claim credit and access the activity materials. And stay tuned for online activity that is based off this event.